think of an epithet, so if anybody has a good idea, please let me know. But I'm delighted to talk to the Children's Hospital Research Institute of Manitoba. And I am on a busy, and I don't think I should be working so hard. These are my disclosures. So the aim of my talk today is really to describe what I think the MDCTR would like to be and discuss its aims and our progress to date. But really, I have to go back probably 30 years, 25 years, 20 years at least, and really, as a geneticist, I know that any of the advances in our field, and probably many of your fields, it starts with basic science. And Barbara Blaine started the Center for Investigation of Genetic Disease, and really, this is the wheel that we, I know I don't touch the screen, but how do you point or you don't?
Just don't touch the screen.
But, you know, much of the work that we've done over the past several decades started with basic science, with that gene identification, understanding pathophysiology. And now, for much of where we're at now, we're at the knowledge translation phase with prevention and with treatment trials. And so today I'm really going to focus on the work that I want to do during my mid-leave and follow-up related to that part of the second investigation on clinical trials. So what is the MDCTRC? Well, it's certainly not, it's trying to be a very inclusive group of people from multiple disciplines, professionals who are committed to inborn errors of metabolism, which are rare or ultra-rare disorders. And our team is dedicated to developing a framework and really to provide the infrastructure for clinical trials for new drugs and treatments for these inborn errors of metabolism, and also a framework for ongoing surveillance. And really, the clinical metabolic service is a very busy service, and really, it's grown so much and things have changed so rapidly that, you know, we have to have a clinical trials research team to deal with that arm of our work, because it cannot fall just entirely on the clinical service, because it's just too much happening too rapidly. And it will allow us to provide, I think, a mechanism not just to contribute locally, but to have some credibility nationally and internationally to contribute to a growing body of evidence about efficacy of certain new treatments that are coming down the pipe, as well as in helping to find natural history, really work up new treatments through clinical trials, and then things that I'm particularly interested in during some aspect of my min-leave is working on the issues related to applications for licensure, of access to medications and new treatments, and of course ongoing surveillance for safety. So this is part of our team. This wasn't John McGavin, though. Erica Bluefield is somewhere. I added her picture because she just started to work with our team this past Monday, and we're really delighted to have her. She's over the picture of a genetic counselor who left for Edmonton, so this loose group of people in our MDCPRT are the people involved in clinical trials for hypophosphatasia. They're Amy, Barb, Stacy, and Ed, and Bob. Our colleagues within the clinical chemistry with Dr. Lauren Sargent, who is head of the Metabolic Lab. We have a physiotherapist, Kim and Corey, yeah, who are part of the Hypophosphatasia clinical trials team. The genetic counselor within our team is Jess Hartley, and we're trying to recruit for our PEDS metabolic program and adult metabolic genetic counselor. And of course, the clinical colleague in all this is Aziz Mani, myself and Patrick Frost, who's just joined our team. Now you may wonder, how come there isn't anybody from genetics here today? Well, we happen to conflict. There is that's kind of a party for Chudley, who has stepped down as medical director for genetics, so that's where everybody is today. I couldn't be there. So, what have I done to date? As I said, I think I've been working too hard, but I'm trying to organize the facts and enhance the documentation of 50 patients to date who have rare or ultra-rare inborn errors who are enrolled in various clinical trials or in clinical trials not of enzyme replacement therapy or substrate reduction therapy, but in clinical trials for other new therapies and in enrollment in patient registries. And I think my greatest achievement to date is being able to hire and have been assistant to the absolute Erica, who will help bring this all together and, in terms of helping many aspects of our clinical trials and our applications. Created a shared drive here in the Research Institute for our team. And I'm trying to spend a fair bit of time working with senior management and other people at the WRHA, with the provincial government and the national partners to help create a Canadian national strategy for rare and ultra-rare disorders. And, I think by having a research team, this will help us in expediting licensure and to facilitate reimbursement protocols for orphan drugs for ultra-rare diseases. And to date, I'm still very busy working with industry and with advocacy groups. So what is an orphan disease? So it's defined in a variety of means. In our field of metabolic genetics, orphan diseases are single gene disorders. Monogenic disorders, Mendelian disorders, usually autosomal recessive. And depending on where you live, it's defined in different ways in terms of the number of people per the population who are affected. You may notice that Canada does not have a definition for an orphan disease as yet. And several countries have developed very good incentives for development of orphan drugs for rare and ultra-rare disorders, because these are very rare disorders. And industry, of course, is in terms of being able to capitalize on investment, need to have some incentives to be able to afford drug development. And I know many people like here and others are involved in various aspects of drug monitoring. And there is a Orphan Drug Act in the U.S. There's a very good framework for orphan drug development in the EU. We do not have any legislation or any strategy in Canada for an Orphan Drug Act or a strategy for rare diseases, rare inborn errors of metabolism. Now, as I said, the work that I work is on very rare disorders. There are about 7,000 Mendelian disorders that are single gene, and more of these, about more than 550 we would define as inborn errors of metabolism, where there is a single gene that is causing a block in a metabolic pathway because either the enzyme missing causes accumulation of the substrate before it, which is toxic, or the lack of the end product is what leads to disease. And so these are usually single gene disorders, individually very rare, but collectively at the hospital really form a significant burden of disease. And I don't have the stats, but I had some in terms of at any one time there's probably 3 or 4 children with inborn errors in hospital for treatments for metabolic decompensation, often for very prolonged periods. I want to give some 2 very quick examples of the work that the clinical research unit here in the research unit has helped us enormously in some of the clinical trial work. And I'll talk about our most recent example with glycogen storage disorders. So glucose, as you know, can either be metabolized to make energy or it can be stored as glycogen. And glycogen is a glucose polymer. It's joined in straight chains, both either alpha 1,4, alpha 1,6 linkages, and it forms a tree-like structure, and it's stored in the liver and muscle and heart and various organs. And there are a series of inborn errors of metabolism that cause excessive storage of glycogen in the liver. These are glycogen storage disorders or hepatic glycogenoses. And they may involve more than the liver, but they predominantly involve the liver. They cause really severe enlargement of the liver. Often they have severe hypoglycemia, growth deficiency. This is about chemical characteristics. And there's 5 main subtypes. The most common is GSD, or glycogen storage disease type 1, of which, as you can see, these are rare disorders, but these are very important disorders. We follow now actually 9 pediatric cases and probably more than 3 adults. Now, how do we treat? Okay, this is showing glycogen storage disease type 1 is caused by deficiency of glucose 6-phosphatase. It's a missing enzyme in the activity of glucose 6-phosphatase. And this is the final common pathway for gluconeogenesis. If you're missing this enzyme, it doesn't matter where you are and what you've eaten or when you've eaten, the only way you can make glucose for anybody is we have to have a functioning glucose 6-phosphatase enzyme. And if you are missing and have a mutation that is affecting the activity of this enzyme, then you really cannot do that final step of gluconeogenesis, and you actually run into serious problems. You run into problems with severe hypoglycemia because there's no way you can keep your blood sugar up if you're fasting when you have this disorder. You get accumulation of glycogen, and then you get a lot of mobilization and many other pathways to try to compensate for that defect of gluconeogenesis. And these children, when they present with severe hypoglycemia, usually hypoglycemic seizures, they usually present around 4 to 6 months of age when they start to sleep through the night and they're not waking for feeds, and naturally they can't tolerate fasting, so they get hypoglycemic seizures. They look very healthy. They're described as being very cherubic. But in fact, untreated, it's a devastating disease. They get severe hepatomegaly with wasting. There's a glycogen accumulation in the liver. The mainstay of treatment, if you don't have that final enzyme of gluconeogenesis, you really just need a continuous source of glucose. So during infancy, really, these kids are fed a lot, and they're fed often, and they need a continuous source of glucose overnight. We have always used continuous dextrosolution through a gastrostomy tube when the kids are sleeping, because they can't tolerate it fasting. Other centers exclusively use just cornstarch, just uncooked raw cornstarch, which is, again, a glucose polymer, kind of slow-release glucose, which they give around the clock every 3 to 5 hours, and to keep their blood sugars high. We use cornstarch during the day, and we've always used continuous gastrostomy feeds of dextrose overnight. Now, more recently, VitaFlow developed a extended-release engineered cornstarch therapy. And this modified cornstarch was said to prolong the period of maintaining euglycemia and be much better tolerated than cornstarch, which often has caused diarrhea, stomach aches, causing quite an osmotic load. So the hypothesis is that this cornstarch will allow our patients to actually sleep through the night without continuous dextrose infusions via gastrostomy tube and have improved quality of life without sacrificing metabolic control. The problem with the gastrostomy tubes is that there's always a risk of the danger of entanglement, particularly very young children, and dislodging of the tubing so that the dextrose gets infused into the bed sheets, and then the kid gets hypoglycemic and still seizes overnight. And so the anxiety in raising a child and the work involved raising a child with GSD is enormous. So David Weinstein, who is a pediatric endocrinologist and really a GSD1 specialist, he has always used cornstarch around the clock, and he's done much of the preliminary clinical trial work on glyphosate, and he wasn't using continuous infusion, but the blue bar shows the 1A patient, because it is used in other glycogen storage as well. And we were able to demonstrate very nicely the enhanced length of euglycemia using glyphosate. So with the help of people in the CRU, particularly Janine Schellenberg, Carolyn under Susan's guidance, we were able to develop a protocol and secure funding through a lot of fundraising by parent advocacy groups to compare the effect of glyphosate versus gastroscopy dextrose infusion on the impact on overnight euglycemia control. This was an open label demonstration trial. It was CRU-led. To date, we've admitted 4 patients over 5 years of age. The treatment has been limited to kids over 5. And we can talk about why that may be after. They came up here to the institute, got some baseline blood work, and then they were brought over to Children's Hospital. They were admitted overnight. They got a single dose of glyphosate about 9 o'clock at night, usually administered through their gastroscopy tube because it's still not that pleasant to drink. It comes as a powder. And they didn't get any overnight continuous dextrose by gastroscopy tube. Carolyn, CRU nurse, sat at their bedside overnight, did their blood sugars every hour, 2 hours, and actually they were euglycemic. And they wake up in the morning, and some of these kids, they couldn't believe that they actually had slept all night, and their blood sugars were still good. So it was very exciting. It was really very, very nice. And these 4 would maintain their euglycemia overnight for at least 8 hours, and they're now all transitioned to a single dose of glyphosate for overnight treatment. And I can't, we're doing a lot for biochemical surveillance and quality of life surveys, and it's very exciting today. The challenge now is not the challenge of glyphosate. The challenge now is the reimbursement, because you're going to Safeway and buying a little box of cornstarch, versus Vitaflo, which I know the annual cost, compared to most of our drugs, is really nothing. It's probably about $5,000 a year, but it's still a lot more than buying a box of cornstarch or a vat of dextrose at the beer store, for overnight continuous use, which is what they do now. So now, part of my challenge, and during my admin leave is reimbursement, and I'm very busy working with a dietitian and other members of the team who worked in the picture. Nicole Aylward is really helping us with requests and in this whole mechanism and the complications of adding a non-drug. This is not a drug, this is a supplement to a formulary for reimbursement becomes very challenging. But I'm really grateful to everybody in CRU who helped very quickly get this trial underway. And the results to date are excellent. We have about a 6-month supply of glyphosate in one of the storage rooms here. We're just so I have 6 months for reimbursement, but so I feel a little bit of pressure now, just because nothing moves fast, right? Now PKU is an inborn metabolism caused by deficiency of the enzyme phenylalanine hydroxylase. So phenylalanine, which is one of our 20 amino acids, that is converted to tyrosine. And when you don't have activity of the enzyme, phenylalanine goes up, and high phenylalanine is very toxic to the brain. Currently, we follow a fair number, sort of our more common inborn areas of metabolism of children and adults with a PKU from Manitoba, Northwest Ontario, and even some of the Saskatchewan patients up here now. And the mainstay of treatment of PKU has always been diet, and continues to be. And the diet, to restrict phenylalanine of the substrate so it doesn't go high, you require special formulas that are phenylalanine free, special low protein products, and there's now a tremendous variety of low protein foods that is making life a lot easier for the patients with PKU. However, we know, based on and certainly published consensus statement, that treatment with a low phenylalanine diet is lifelong. It's very challenging. We take probably about 3,000 milligrams of phenylalanine in our diet every day. Kids with PKU and adults with PKU cannot tolerate more than about 200 to 250 milligrams, which is probably equivalent to about 4 slices of bread a day. So it's very challenging. And we were fortunate to work with the CRU, and in this case, Lee's was a tremendous help. We were one of a variety of sites to see that enrolled patients to a double-blind, placebo-controlled, randomized, multi-center trial of sapropropyrin dihydrochloride, also known as BH4. That's that cofactor, the helper to the enzyme PAH. And the purpose of the study was to look to see if this was going to enhance any residual activity of the enzyme and allow us to liberalize the diet of these kids with PKU to improve their quality of life. So this was just a summary of the various sites. This is Dr. Manny was really leading this. And actually, for being a relatively small center, we screened and enrolled many more patients with the help of everybody, the CRU, than some other sites. And really, how did we first have to define if someone was a responder to BH4, which is the trade name is Kuvan, and we looked for a reduction from the baseline phenylalanine levels of about 20% or more. So if you responded to Kuvan challenge, your phenylalanine level dropped 20% of what it would normally be without any other changes in your treatment. And 8 of our 13 patients showed a response to treatment. We showed that really we would predict that the more severe PKU patients would not respond, and that's generally, the dogma is, but actually, we really couldn't predict who would respond and who wouldn't respond. And BH4, Kuvan, sapropyrin, is now a licensed product, and it really forms a valuable therapeutic alternative and really helping the kids liberalize their diets. A good example, just one example, is a boy, he's 16 years old now, always very good dietary compliance, which isn't always the case in this very challenging disorder, and he's always run good baseline phenylalanine levels that are well within therapeutic levels of 250. Your phenylalanine levels would be 50, that's normal, but keeping a level of 250 is well within a therapeutic range and of no danger to the brain. And he had a very limited amount of phenylalanine he could take in his diet, 300, but he was doing extremely well. When we gave the challenge of Kuvan, his phenylalanine cell, you can see was very low to 26. And with ongoing surveillance and monitoring, he's now able to tolerate 900 milligrams of phenylalanine in his diet, which may sound insignificant, but is not insignificant to a teenager who can go out with his friends now and actually have some fries at McDonald's or something, It really is it's tremendously exciting for him and his family, and his phenylalanine level remains very good. Our problem with Kuvan is that, yes, in our patients who are responsive want it, and reimbursement strategies are not well outlined, and many of the patients that have these think, well, if we give on Kuvan, we don't have to follow the diet anymore, and that's not true. So we have ongoing work with our clinical service in our metabolic clinic that they have to understand they have to continue to follow the diet and have responsibilities to come back for ongoing surveillance. But it was really excellent with the work and the help that Lise has done to help us implement this clinical trial. Some of the other clinical trials we've been involved with, I think many people have heard about our clinical trials of enzyme replacement therapy for our lysosomal storage diseases. And I've talked many times about the work we've been able to do in hypophosphatasia now, which is really been a tremendous exciting event. And I promised myself I wouldn't talk about it. I talked about it so much that it's hard not to, right? But the results have been, so exciting. You can see for our lysosomal storage diseases, these products are now approved in Canada, and the cost per year very, very high. And we do not have a good reimbursement strategies, and we do every case is on a case-by-case basis, and it is very challenging. But we have 6 patients with Gaucher on it and ERT, and 1 on substrate reduction therapy. They didn't take part in the clinical trial here, but we're doing additional clinical trials for other storage diseases through the help of the CRU. And this is some of the approved products by Health Canada now, and our patients And the clinical trials that we're doing for storage diseases, predominantly for Fabry disease, which is a glycolipid storage disease, we actually are now up to about 25 patients. For many years, we never had a patient, and now we have so many patients. And it's interesting because Fabrazyme is an approved licensed product in Health Canada, and where industry and government are negotiating a pricing listing agreement and reimbursement strategy. But Repligal, which is a human recombinant enzyme as well, but from another company, is still under clinical trial, phase 3 clinical trial. So we have a Fabry patient who meets criteria for entry. It's a national study, randomized either to Fabrazyme, which is an approved product, to the Canadian Fabry Disease Initiative, or to a phase 3 clinical trial of Repligal. So it becomes very complicated, again, without the help of a lot of administrative assistance and coordinators. It becomes very challenging. I don't want people to read this, but really kind of a table of all of our 50 patients, a variety of treatment trials to date. And for a variety of diseases, these are the ones that are still in clinical trial. If there's no check here, it means they're approved treatments. And this list grows every day. So just a word about hypophosphatation, because I think it really, I really want to illustrate some points about it. It is a disorder of skeletal mineralization caused by the lack of activity of a tissue non-specific alkaline phosphatase. And abnormal skeletal mineralization is the hallmark. And when you cannot mineralize your bones, it causes multiple systemic effects, predominantly respiratory compromise, and a variety of other complications. There's no approved current treatment for hypophosphatasia, and there's supportive measures only. And I think you've seen this slide before, that the disorder is on a clinical spectrum, from a real lethal disorder in the perinatal or early infantile period with absent skeletal mineralization, to a more mild form where you just get premature loss of deciduous teeth with odontal hypophosphatation. And there's a variety of spectrum of presentations in between. If you have an infant with hypophosphatation and do nothing, or put them, have a tracheotomy to keep them alive, your bones naturally demineralize. So that is the natural history of the disorder. And we were fortunate to be the site that was chosen for the first phase 1 patients, where the first human was given an infusion here for safety, after preclinical studies in the knocked-out mouse model proved to show effectiveness of enzyme replacement therapy with human recombinant bone-targeted alkaline phosphatase. So this is a product that was developed initially by Inovia Pharma Montreal, now bought out by Alexion Pharma. So it's a dimer of tissue non-specific alkaline phosphatase linked by Fc fragment to a tail of 10 aspartic acid residues. And this is the motif that targets it to bone and retains the bone, and that allows for effectiveness. As the young in our group, we published the overall survival of our hypophosphatasia cohort, which is predominantly Mennonite, but not exclusively, where we have 100% mortality by 8 months of age with our perinatal infantile hypophosphatation. And as you know, we've been fortunate to be one of the bigger sites for enrollment of patients, and Amy, Barb, and Stacy, and Bob and other, and Janine does indexes, and the pharmacy. There's a whole team of people involved in our many clinical trials. And in addition to the retrospective survival analysis for our Mennonites, the overall survival worldwide was, in a retrospective historical control, really had a 42% one-year survival. Ours was a 0% one-year survival, but it's a slightly different population. And there's many studies that have either completed. The ones that are ongoing is continued follow-up of the juveniles, ongoing for the adolescents and adults, and we continue to enroll to the infantile trials. And even this summer alone, we enrolled 3 new infants, and a 4th one is coming on Monday, I think. very exciting, and the survival and the data look really wonderful. That if you treat, this is for the infants and very young children, there you can see the overall survival in terms of these Kaplan-Meier curves show highly significant improved survival compared to historical controls. And this is just showing again some of the radiological improvement of the chest of a baby with very severe hypophosphatasia who's intubated, and then ultimately a chest X-ray that's normal, that really and bones in the knee that are indistinguishable from control. So it's a very good product, and to the point where now Alexion just put out a news release yesterday that on December 30th they completed the rolling submission for licensure of aspartame alpha for treatment of patients with hypophosphatasia. So this came out, it was just a press release yesterday, but the submission was completed at the end of December. And Alexion Canada has submitted to Health Canada for approval last month as well. The request for approval in Canada is a bit different than the States. It's not a rolling submission. It's approval for treatment of anybody with hypophosphatasia who meets criteria, who had disease onset less than 18 years of age. So these are just some examples of the work that we've been doing up here for all members of our clinical trials research team, but there are other studies certainly ongoing. Just want to talk about some of the challenges that I hope to be able to face in the next stage in my life is the challenges of working with drugs for rare diseases. Because many of them, as you know, for rare diseases, we don't know the natural history. These clinical trials, although we've had 7 years experience now with hypophosphatation, it's still limited, and we're very excited that the safety profile looks excellent, but there's still short clinical trials, and the numbers are still really small compared to the millions that would be on Lipitor or whatever. The evaluation process after approval by Health Canada through the Common Drug Review Committee is very challenging. Very few of our metabolic products have ever obtained approval through the Common Drug Review, which is the mechanism that the provinces use in order to decide whether or not they're going to reimburse or not. And you can see the CDR recommendation rate, once Health Canada has approved the drugs, for addition to formularies is only 14%. So we're not doing very well in getting approval for reimbursement. And yet across the country there is disparity in the percentage of drugs that are reimbursed, and many drugs are still under review. So I spend a lot of time now working with special access applications, trying to work with governments. And for us in Manitoba, we don't have any overall strategy. It's really on a case-by-case basis. But the one thing that I have been doing is trying to understand philosophically, does the government accept the fact that children or adults with ultra-rare diseases, doesn't matter the cost, do you philosophically believe that they should have access to treatments that are felt to be effective? So if you believe that philosophically, then we can work together to come up with some reimbursement strategies. Why these drugs are priced so high, I can't tell you. There's market exclusivity for at least 20 years. But try to stay away from that part of it and just, of course, advocate for the patient. Just for the sake of time, I won't go over some of the efforts, but there are efforts in a variety of provinces to have special processes of reviewing drugs for rare diseases. And I hope over the next year to work with the government here and really we have a very good relationship, but we need to formalize our relationship for expedited review and approval for drugs that get Health Canada approval. I've participated in a variety of meetings that have been held looking at trying to develop a pan-Canadian strategy for orphan drugs. And when the ministers get together, they do talk of a variety of healthcare challenges, and it was nice at the last meeting in September that orphan drugs was a topic of discussion in addition to flavored tobacco and e-cigarettes. So it's on the agenda, and I'm happy to see that. So our team, as a multidisciplinary team, and I haven't mentioned everybody, really thinks it will be value added to work together with a group of people from multiple disciplines, dedicated inborn errors, and that we can contribute locally and nationally to patient care for our patients and families with inborn errors. But the challenges within our field really also speak to the importance of having a very active research team for clinical trials for inborn errors, you know, because the field is rapidly evolving, and this is from the Consortium for Research for Drugs for Rare Diseases, and, you know, by 2020, there'll probably still be 200 new therapies that are available for rare and ultra-rare disorders, and we need to have a mechanism that allows us to work with the clinical trials team, with the facilities that we have here, to take part in as many of these clinical trials as we can, that's realistic, because they're very rare diseases, and we can help contribute to the overall body of knowledge nationally and internationally, and to work for strategies for market authorizations. And there are a variety of working groups. So I want to just switch for the last 5 minutes, leave some time for discussion, from the work on clinical trials and the exponential increase in the potentials for treatments, to the work that the research team is doing as part of working with research networks. And at the top, I listed 5 networks that our clinical trials research team are actively involved in. One is, this is a great acronym, CIMDERN, the Canadian Inherited Metabolic Disease Research Network. And we're very actively participants in that, and the clinical research unit has helped us become one of the more active partners within this research network. And we belong to the Canadian Newborn and Child Screening Network. We're certainly part of the Canadian Fabry Disease Initiative, Care for Rare, and I'm very much involved with CORD, which is the patient advocacy group and the umbrella group for all rare and ultra-rare metabolic diseases. More recently, we are also partners in an initiative called Phenome Central, which is led by Michael Brudnell from SickKids and Dr. Kim Boycott, geneticist from CHIO in Ottawa. This is a very exciting initiative. It was born out of a pan-Canadian initiative recently called Care for Rare, which we also participated in, and it's trying to go beyond. Care for Rare was a strategy to identify disease genes, and many new genes were discovered. Okay? So it's taking it to the next level of developing a portal internationally that you can enter data on disease genes and match them to clinical features. And if you belong to this consortium, and it's not exclusive at all, anyone can belong, and we have active partnerships. It is trying, it allows to store clinical and genetic information on rare disorders, and we can upload our information into a secure database, and then simultaneously try to match patients of certain phenotypes with genotypes, and will allow for faster diagnoses and better access to treatments. And as part of Phenome Central, we're also going to be part of a variety of international rare disease research consortiums in this field. This is just some of the stuff related to CIMDERN, which is a very exciting network, because all children in Canada with rare inborn errors are treated at 16 different metabolic centers across Canada. And what CIMDERN is trying to do is identify the differences in treatment, because there's huge differences in treatments depending on where you live. Protocols are not consistent, and really trying to accumulate rigorous evidence based on observational data and other strategies of collecting data to have a good consensus about for practices for how to treat these disorders. And this is a funded, CRHR funded grant until 2017. It's led by the CHIO group, but we are led by Beth Potter as Prana Chakraborty, and we're part of this network. And this is the kind of, there is a map of Canada somewhere in there. So most centers in Canada are involved, and through the help of the CRU, we've been able, again, begin to enroll patients, and it is going to evolve, we hope, into a sustainable research network for pediatric inherited metabolic disease. And we belong to a variety of working groups that are focusing on various aspects of research. And the belief, and where we in our team feel, is that if you identify and understand patterns of intervention and systems of care, we can really offer the best outcome for our patients. And we hope that it's going to be a sustainable network and a resource. We're focusing on 29 inborn areas. We are one of the centers that has REB approval and has begun to enroll patients. And the data are secured in a REDCap database through CHIO. And we've already begun to enroll. These are some of the activities of Center. So, in summary, what am I doing on my admin leave? So, this year, what I really hoped it was going to be was a year to take stock of my life and have maybe some spare time and have maybe achieve a little more of a work-life balance, spend more time with family, my grandchildren and friends. But the reality is research excites me, my work excites me, it always has, and I do feel the pressure of time. When I was at Grand Rounds today, Stan Lipnowski, who is a pediatrician at the Manitoba Clinic, he was muttering. I said, what are you talking about? I said, do you know that in a few months we will be closer to 2030 than to the year 2000? And that's when I tell you about feeling the pressure of time, it just, consulted, it made me just feel even more the pressure of time. Because I know, I do feel the pressure of time, and I'm happy to, this is kind of my next 5-year plan, to focus on this field of metabolic genetics from a research perspective. Because I know the field by 2030 will look very different. Newborn screening will be very different. We'll have many more treatments that become available. And the hope is that our research team will help lay the groundwork for the exciting advances that the new and innovative technology is bringing to the field. We want to be sure we're at the forefront of research in rare and ultra-rare disorders so that our patients and their families are best positioned to reap its benefits in the future. And I know that we're very well positioned to work up here within our research institute. So yesterday or Monday, I forget when, Tuesday, Terry, I asked to borrow the slide, because he was talking about how we really have to develop a research hospital theme, and I really totally support that. And the outer circle, of course, is the big system stuff. But I'm still very much involved in the inner circle, and very much committed to the concept of a research hospital to accelerate advances in our field. So I just want to thank everybody, and I know, unfortunately, I'm sure I'm going to leave people out, but the staff in the Research Institute have welcomed me with open arms and have really helped me, get settled at my desk. The clinical research unit led by Theert and Susan, and I hope I haven't left people out who've been, these are the ones who've been particularly involved with some of the clinical trials other than the hypophosphatasia stuff, but certainly hypophosphatasia support that the staff at the CRU has also been tremendous. My colleagues in genetics and metabolism. And we do have a very supportive University of Manitoba Research Ethics Board, I find, and the impact committees, both at the Children's Hospital and at HSC. It's a slow, arduous process, but it's one that we have to do. So thanks very much.
Cheryl really has been achieving the balance to some extent, because I thought you'd have slides of Maui and her on the beach over the holiday.
I could have shown you that. I could have shown you what I was doing from the beach on
I
Maui.
can imagine.
Yelling at Health Canada. I think the hypophosphatasia people do. I can only begin to tell you the runaround and get. So that's what I did from Maui. Yelling at Health Canada.
Great, so time for questions or comments or Heather?
Quick question. One philosophical one, and your study in the glycogen storage disease, when it's an open label study design, you've got a small number of patients. What happens in your world when you've got highly motivated patients, but when a family can't quite maintain it in terms of the rigor, and you've got an open label study and you've enrolled all of the kids with glycogen storage, what happens with those?
Well, I do believe sometimes you have to say no to families that we cannot give you this medication because it absolutely, we have to do our due diligence.
So you still have exclusion criteria in terms of being able to follow the protocol?
Absolutely. If they're not willing to follow the protocol, then I'm sorry, you can't get it. You know?
So one of the privileges, so to speak, of having a population like this is a highly motivated population of families.
Yes, but we have parents whose kids are not enrolled for a variety of reasons. And mostly because they are not able to comply with the protocol.
My second question relates to the paper, or I guess the report that Terry and the group put out from the Canadian Academies on drugs and drug approval for children in Canada. I was looking really for drugs that are licensed for use in adults and looking at the process for making sure that they were held back, so to speak, until they've done some studies in children, in which there's a disease that might be appropriate in children. But in your case, did that report address the orphan drugs, the orphan diseases? And what impact does a report like that have at Health Canada when it's done by an astute body of people across the country who spend a lot of time on writing a report like that?
Well, for many of these diseases, they are affecting children. So when Health Canada gets a submission, they have to analyze it, because the data are, the approval is being asked for children and or adults. So the research is being done with children. We have, that is our patient population. So for most of these, we are not extrapolating from evidence in adults and asking it to be used for children.
But in your case, so in that report, did it start with rare disorders like you have that started in childhood, so you're really only looking at childhood first that happens to grow up?
In fact, in hypophosphatasia, we're not going to have problems with licensure for infants and children and younger. It's the adults where efficacy has been, whose disease has been established for many, many more years, where efficacy is more difficult to prove. Where Health Canada, that's why Alexion Canada has applied for licensure for children, for people who, with hypophosphatasia, who had onset of disease before 18 years of age, because the data are not, they're good, but according to Health Canada, they're not robust enough for adults, and we're not going to be short of work. We have other clinical trials for adults for hypophosphatasia coming.
So I saw gene therapy on one of your slides that you didn't comment. To me, this seems like something that's really necessary given the cost of all of these enzyme replacement therapies. Do you have any trials that are coming to Manitoba for gene therapy? I just wondered. And are there any in
There are several in progress, none that we have been invited to enroll patients. There was one for urea cycle disorders where the PI is in Calgary and Yukon, but there's not that many where Canadian sites are one of the sites for gene therapy trials. That is an area that I need. But I do believe gene therapy is a solution.
It's a remarkable body of work. Congratulations.
Yeah. do when she's back at work?
I speak for that.